Session. I would now like to call upon Dr. Vijay Amrutkar onto the stage. He is a senior consultant in the Department of Medicine at Deennath Mangeshkar Hospital and a DNB teacher at Deennath Mangeshkar Hospital for medicine students.
Our next chairperson, Dr. Atul Deshpande, sir. He is a senior consultant physician at Deennath Mangeshkar Hospital and a recognized DNB PG teacher. We request chairpersons to invite and introduce our speakers for the next session.
The first speaker is Dr. Rajesh Chawla. He has already been introduced. I request him to give a talk on NIV.
Thank you, sir. So I'm going to talk about a very important topic which over the last 2 decades have really progressed, and that is about non-invasive ventilation. When you talk about non-invasive ventilation, that is the application of ventilation or augmentation of ventilation without a conduit access to the airways, that is, without an endotracheal or a tracheostomy. Over the last 2 decades, the non-invasive ventilation has really become the standard of care in treating acute respiratory failure. And it's because of obvious advantages you are all well aware of. And a lot of papers have been published and guidelines have also been published, the recent being by the European Respiratory Society and American Thoracic Society, which was published in 2017. So my talk is practically going to around this and another guideline which was published by the BTS on the hypercapnic respiratory failure. So how does non-invasive ventilation act? You know, there was a very small study done way back in 1998 by Dr. Laurent Brochard in 12 patients of COPD, where he showed that when patients were given non-invasive ventilation with pressure support in a patients, they showed that when the pressure was applied, there was a decrease in the diaphragmatic pressure, the EMG was also less, and the flow was normalized. And it was associated with increased tidal volume, the increased minute ventilation, decrease in respiratory rate. In addition, there were improvement in PaO2 and decrease in PaCO2. So it is really effective. It improves ventilation. It increases oxygenation in these individuals. So where do you use this? You use non-invasive ventilation early in the course of illness as a measure to avoid tracheal intubation. And then second, when you are thinking of endotracheal intubation, you give a trial of non-invasive ventilation as a measure to avoid intubation. And third is not a candidate, a terminal cancer, congestive heart failure, crippled COPD, that's another third who refuses intubation. And during weaning from mechanical ventilation. It's not a substitute for endotracheal intubation. If a patient cannot protect airways, non-invasive ventilation cannot be used. It's only a way to prevent it by providing support early enough before the severe derangement takes place. So this must be very clear to all of you. And these are the 2 guidelines which I am going to discuss. Non-invasive ventilation has the strongest recommendation, the maximum evidence in 2 conditions, and they are the hypercapnic respiratory failure in COPD and cardiogenic pulmonary edema. We have n numbers of paper in both RCTs, meta-analysis, where they have really showed the efficacy. In COPD, we have the strongest, where they've shown that not only decreases the intubation, it improves survival in the patients. So, patients who are not acidotic, the non-invasive ventilation should not be used. If PCO2 is high, pH is normal, then probably this is not the modality. But if patient is acidotic, pH is less than 7.3, we have the strongest recommendation of advising non-invasive ventilation in addition to the medical treatment. When a person is being considered for endotracheal intubation, patient is drowsy, you feel pH is 7.15, you are thinking of intubating, you could give a trial of non-invasive ventilation. Again, there is a moderate certainty of evidence, but strong recommendation, you could still use it. There is no lower limit of pH below which a trial of NIV is appropriate. The lower the pH, the greater the risk of failure. So you need to be more observant when you are ventilating for a patient who's got a pH of 7.1, because if he dips, you will have very less time to intubate this patient. Then the second hypercapnic respiratory failure condition is a neuromuscular diseases and the chest wall diseases. Oxygen therapy to maintain 88 to 92, which I said little while. NIV should be considered even if they don't have acidosis. In this condition, if the carbon dioxide is high, that's the indication to use NIV in neuromuscular diseases. You don't wait for the pH to be low down to use this. You monitor their vital capacity. If it is less than 20 ml per kg body weight, then probably this person should be. Similarly, in patient with neuromuscular disease and chest, consider controlled ventilation as triggering may be ineffective. So you have to use the AVAPS kind of a machine where patient does not trigger, it gives a breath to the patient. Or you use an ICU ventilator with a backup rate. Intubation should not be delayed if NIV is failing. Wait for 1 or 2 hours, not effective, intubate. Otherwise, this person will have a sudden cardiac arrest. Obesity, hypoventilation. Again, control oxygenation to maintain 88 to 92. And again, NIV is indicated if person is hypercapnic, somnolence. In the absence of acidosis, you still use in this condition also non-invasive ventilation. These patients will require very high EPAP, like something like 30, 8 or 10 EPAP. That's the requirement. And you should give a forced diuresis to these patients. They will do better, they will not get intubated, because keep a watch on the potassium and give a diuresis to these patients. Acute asthma, the evidence is not enough. So there is uncertainty of evidence, so unable to make any recommendation, but personal view is that if patient is failing, give a trial of NIV, a short trial of NIV, 1 to 2 hours. If it's succeeding, your bronchodilator and steroid may be effective and you may be able to avoid intubation. Fortunately, asthmatics, hardly any asthmatic gets intubated nowadays because we use steroids very early and most of them respond to steroids. Second condition in hypoxemic and sometimes hypercapnic is the acute cardiogenic pulmonary edema. It decreases intubation, increases the survival, decreases mortality, and CPAP and NIV are equally effective. Doesn't increase MI as was thought of initially. So the guideline recommends NIV or CPAP for patient with acute respiratory failure due to cardiogenic pulmonary edema. It can also be used in the pre-hospital setting. When patient is coming or patient on the way, this can also be used as to avoid, so long as your diuretics and oxygen and other things are acting, this could avoid intubation in these patients. Then non-invasive ventilation has a role in weaning, but that too in COPD patients. It decreases ICU stay, mortality, and ventilator-associated pneumonia, but has not been found to be that useful in patients who are hypoxemic. So there is no recommendation for using this in a hypoxemic respiratory failure. Then what is the role of NIV in acute hypoxemic respiratory failure? Somehow we've not found it to be that good as in hypercapnic respiratory failure. There are various meta-analyses which have shown the decreased intubation and mortality, but they had a varied kind of patient in these studies. Immunocompromised patient, this study showed that there was a decreased intubation with NIV, but what they found was if you failed NIV, the mortality was 79% as compared to, so you have to be very observant if you use an immunocompromise. If you delay intubation, then the mortality is high. The problem is the non-invasive ventilation maintain oxygenation very delayed, till very late. You know, the problem is the physician, the family, everybody wants intubation should not be done. And in that process, you delay intubation and increase mortality. So if the PF ratio, that's the criteria, if the PF ratio is below 150, howsoever patient is looking, please intubate in hypoxemic respiratory failure. N number of studies have shown, so you should not delay the intubation. This is another study in immunocompromised. They did not find much difference in mortality, but they could find some difference in the intubation. So the guidelines suggest that NIV could be used for immunocompromised patients with acute respiratory failure. This is a real life situation where they found there was a more chances of failure if you use it for hypoxemic respiratory failure. Internally, who's written a lot of papers on non-invasive ventilation, found that even in severe patients or a moderate severely ARDS, he used and found success in almost 54%, and he found SAP more than 34 and PF ratio less than 175 was associated with the NIV failure. Then this is another study by Thilev who found that it was only useful for mild ARDS. Moderate and severe ARDS, it was not effective, and there was an increase in mortality. So PF ratio less than 150, shock, they were the predictor of failure. We did a study about 179 patients of ARDS. Out of that, 70 patients were H1N1 patients, and we also found that the modality should only be used because we found more mortality in moderate and severe ARDS as compared to the mild ARDS. So this is a useful modality in mild ARDS, should not be used in a severe or moderate ARDS. Problem is the oxygenation will be maintained. Oxygenation is not the only criteria. If your PF ratio is below 150, please intubate. And the SAFE study also found the same thing, that the failure chances are 53% and higher mortality if the PF ratio is. Why I'm going again and again? Because people still persist with PF ratio 100, NIV, and when you intubate, maintaining oxygenation even 2 hours after intubation is difficult because he's so de-recruited, recruitment becomes difficult. So if the PF ratio is below 150, you should convert your patient into an invasive ventilation. Because of uncertainty of evidence, this guideline have not made any recommendation of NIV for acute respiratory failure. And same was done by the surviving sepsis guideline. Does the interface has any role? A recently published study of the role of helmet. We are using helmet for last few months. And this was a study on 83 patients of hypoxemic respiratory failure, where they showed it reduces hospital mortality and intubation requirement. The first time an interface has been found, it was just a small study of 83 patients. Probably a larger study would really tell us whether the helmet is better in particularly hypoxemic respiratory failure. Then post-extubation acute respiratory failure. I think many of you must have known about the Esteban study when they used non-invasive ventilation in post-extubation and they delayed intubation by 10 hours and increased mortality. And after that, in post-extubation respiratory, unless there is a high risk of post-extubation respiratory failure, non-invasive ventilation is really not recommended. And should not be used in the treatment of patient with established post-extubation respiratory failure, except probably in COPD patient where you could try non-invasive ventilation. Post-operative respiratory. You know all these complications are very common, and the diaphragmatic dysfunction, atelectasis, pre-existing comorbidities, these are prone to a lot of complications. So non-invasive could be used as a prophylactic and therapeutic. It could be used as a prophylactic to prevent the occurrence of atelectasis and respiratory failure, and when a person has developed, you could use CPAP or NIV. And they have shown that it does restores the lung volume and it does improve the atelectasis. And this was a study in 209 patients of post-operative, and they showed in these patients it could decrease the incidence of reintubation, pneumonia, and sepsis, and it does not increase the anastomotic leak. Because a lot of surgeons used to think because esophageal surgery, it will increase the leak, but they have shown that does not increase the anastomosis leak, and it could be used. So this guidelines also suggest the NIV could be used for post-operative acute respiratory failure. Then in chest trauma, this was a single very good study where patient who had a PF ratio less than 200 for 8 hours on high flow mask, they gave them thoracic analgesia and they applied non-invasive. They showed significant difference in the NIV group and the control group. This study was stopped after 25 patients, and there was a strong evidence of efficacy in these patients who are not very severely ill. So even these guidelines suggest NIV for chest trauma patient with acute respiratory failure. Then for the terminally ill patient or do not intubate situation, in those patients also, NIV can be given to dyspneic patient for palliation in the setting of terminal cancer or other terminal conditions. You know, a word of caution. With its expanded role, it should be known that over an unproven application can lead to failure of NIV, delayed intubation, and increased mortality. I think it is very easy to apply order to a sister, to anybody, but it is even more important when to stop non-invasive ventilation and to convert into the invasive ventilation. If patient is not responding in 1 to 2 hours, he gets saturation of 80% when you remove the mask even for a few seconds. These are the indications, or a person who's getting drowsy. These are the indications that you should convert into invasive ventilation. What kind of mode? Pressure modes are the devices of choice. Both pressure and pressure control are effective, although you could use any mode in this. A full face mask should be usually, or oronasal mask which is called, should be the first type. You should monitor oxygen. Intermittent measurement of PaCO2 and pH is required. And of course, ECG monitoring is always advised, particularly if patient is tachycardic and heart rate is more than 120 per minute. Maintain oxygen saturation. All causes of hypercapnic failure, 88 to 90. Oxygen should be entrained as close to the patient, preferably into the mask, near to the possible. Humidification is not routinely required. Only if there is a mucosal dryness, plenty of secretions, you could use humidification, or patient feels dry, or patient feels cold. In those patients you could. Bronchodilator normally should be administered during breaks for NIV. But if patient cannot take a break, then you could attach in the limb of the NIV to give the bronchodilator. Sedation should only be used under close monitoring. I somehow feel if patient requires a lot of sedation, he should be intubated. But there are few patients who would require very tachypnic, and you give them a little bit of morphine, particularly mild ARDS, hypoxemic respiratory failure. They do very well 2.5 to 5 milligram of benzodiazepine or plus minus benzodiazepine. But I don't use benzodiazepine. I'm quite happy with just the morphine or dextrometamidine, then, which will provide relief and improve tolerance of NIV in these patients. Don't over tighten the mask, because nasal bridge necrosis still occurs in many places. Previous episodes of ventilator associated pneumothorax, you should, if there is a history of patient had a pneumothorax, you should admit to HDU or ICU and use the pressure lower than the EPAP, particularly use lower than the normal. Duration, you know, till patient is better, you give a continuous, give him few breaks. As he gets better, give a break during daytime, give only at night time, and then you can also discontinue if it is a reversible condition. So what are the insights for future on NIV? We need to know early predictors of NIV failure even more. High flow nasal cannula, there is going to development of high flow in conjunction and not an absolute replacement for NIV. I feel this will come in near future. Reduction in use of NIV as HFNAC is making inroads into the use of NIV for hypoxemic respiratory failure, because I predict this will happen. It's a much easier to apply, much easier to convert, and it does have a role in small remove. It gives a PEEP also, and it can remove small amount of carbon dioxide. Extracorporeal carbon dioxide remover will be used instead of NIV in hypercapnic patient at a high risk of NIV failure. So I predict these kind of you are going to see in the coming years. So just a summary, we have the strongest recommendation for hypercapnia in COPD and cardiogenic pulmonary edema. We have a conditional recommendation for rest of the condition, and we have no recommendation for asthma, for de novo respiratory failure like hypoxemic respiratory failure. We have no recommendation. And for pandemic viral illness or ARDS, we have really no recommendation by the guidelines. It doesn't mean that you cannot use this. Thank you very much. So we have first, what are the benefits of NIV in type 1 respiratory failure? It increases FRC, reduces physiological shunt, decreases VQ abnormalities, or all of the above. So not bad. I mean that everybody's awake. Next. Which parameters of NIV affect oxygenation? PEEP or EPAP, pressure support, FiO2, A plus C. Not bad. Next. That's it. Thank you very much for your presentation.
I request Dr. Amritkar to felicitate Dr. Chawla, please.